So, good afternoon, everyone. Welcome to this webinar organized by ERN-EYE, dedicated to cerebral visual impairment today. This is a topic that is a key point in pediatric ophthalmology because it has become the leading cause of low vision in children in Western countries. However, I'm sure that it will be overtaken by genetic causes soon, thanks to the excellent work of neonatologists, nurses, and many other health professionals. We have two Spanish speakers today, and I want to pay a small tribute to Inés García-Ormechea, who was the first Spanish ophthalmologist who worked with these children, from whom we have all learned so much. First, the first talk would be on what is CVI and how to identify it by Victoria Pueyo. She's a pediatric ophthalmologist that works at Miguel Servet University Hospital in Zaragoza. She works with long-term care of yeah. And she has carried out several studies at the baby lab at the University of Oslo because her research focused on visual development and the creation of tools for assessing visual function at any age. She will be followed by Sofia de Manuel. She's a pediatric ophthalmologist that works here at the Paz Hospital. She's a member of my team. She is the responsible of the functional unit, as we call it, with Marta Guerrero, that is our optometrist. And she's also involved in some research projects investigating on functional vision in long-term follow-up of these children. She will talk about how to explore these kids and how to write a report on CVD, that it isn't so easy if you want it to be understood by anyone. So I think that we have a really interesting webinar today. And so let me give the floor to Victoria Pueyo. Thank you very much for being here today.
Thank you so much, Susana, for your presentation. And thank you to the ERN-EYE diseases for inviting me to participate in this panel. It's my pleasure to share it with Dr. Sofia de Manuel, who will talk later. So yeah, we are, as Susana introduced, we are going to talk about cerebral visual impairment. So before starting talking about CVI, I think we should first make like a brief summary about how vision works. And we have to distinguish between the afferent visual system and the efferent visual system. And first, starting with the anterior visual pathways, which goes from the eyes, the optic nerves, the optic chiasm, and from the chiasm fibers project to the lateral geniculate bodies of the thalamus via the optic tract. And we are more interested today in the posterior visual pathways, since they are especially important and relevant in CVI. And from the lateral geniculate nucleus, it goes a geniculocalcarine radiation to the primary visual cortex with two main loops. The major loop, which is the anterior part, which passes through the temporal lobe and carries the information from the upper visual fields. And then the Baum loops, which is the posterior part and passes through the parietal lobe and takes the information from the lower visual field. And it's going to be quite important in CVI. And as you all know, both converge at the calcarine cortex, which is the primary visual cortex or the striate cortex in the occipital lobe. And that's a place where main processes, basic processes from vision are first processed, such as orientation or contrast or spatial frequency or simple motion. And we all know that it's retinotopically organized. That means that each part of the visual field is mapped to a specific area in V1. And then comes the associative visual cortex, which are like several areas surrounding V1, not only in occipital, but also temporal or parietal lobes. And they are so important because they integrate and refine visual information received from V1. And after that comes the mainstream. It is like a very simplified version of how things happen, but we can talk about the dorsal and the ventral stream. And what are these dorsal and ventral streams? They are like functional pathways which are responsible for processing different aspects of visual information. The dorsal stream answers the question where and how about the visual information, and it's involved in spatial awareness and motion and navigation, and it goes from occipital lobe to parietal lobe, while the ventral visual stream answers the question of what about visual information. It goes from the occipital lobe to temporal lobe, and it's focused on the recognition of shapes, faces, colors, memory, and some other visual functions. We will talk about them later. And there is another bundle, which is the vertical occipital fasciculus, which connects dorsal and ventral stream, and is also quite important for integrating all this visual information. It is also important to remember that dorsal visual stream process non-conscious vision, things that we might not be aware we are processing, while ventral visual stream processes conscious vision, such as what am I looking at, or what is this shape or this object. But each of these streams, the dorsal and the ventral, has corresponding anatomical substrates, and the dorsal stream is largely supported by the superior longitudinal fasciculus, while the ventral stream is primarily associated to the inferior longitudinal fasciculus. And anatomically, it's important to take it into account. And so we talked about the afferent visual system, which takes the information from the eye to the brain and processes all this information in the brain, in different regions of the brain. But we have to also talk about the efferent visual system, which takes the information from the brain to the eyes. That means it refers to the motor pathways that control the eye movements, the Bergen system, the eyelid positions, or the pupil size. And these are very complex networks and areas and white matter underlying them, which is not the main focus of this webinar, but are also important, as we will see. So why was this brief anatomic reminder so important to understand CVI? It is so because CVI is not really a pathology. It is more a wide range of entities affecting a certain part of these visual pathways. After many decades without any consensus about the definition, it was quite weird that we could not find like the perfect definition for CVI. Finally, in 2017, a definition was accepted, and it says that CVI, just a second, I'm moving this because it's not so comfortable. Yeah, CVI is a verifiable visual dysfunction which cannot be attributed to disorders of the anterior visual pathways or any potential co-occurring ocular impairment. It's like a quite a simple definition, but takes a lot of important information. It says that it does not mean, it means that the dysfunction cannot be fully attributed to disorders in the anterior visual pathways, but it does not mean that there is no anterior visual pathway damage. And most of the time there is, but they cannot explain all the visual dysfunctions the patient have. Like generally, we can say that CVI is visual impairment originating in any neural insult occurring in these posterior visual pathways. Okay, so as we have seen before, it's like a very wide definition with a lot of possible causes, as we will see, and many different anatomic locations where the damage can take place. So it may have several consequences. So what are the main causes for CVI? Well, actually, any potential damage to the central nervous system, to this part of the brain, can be a cause for CVI. The most frequent is hypoxic ischemic events, especially perinatal ones happening in term-born children. When we talk about preterm children, white matter lesions, especially periventricular leukomalacia, is the main cause. But there are so many other causes, such as infections, metabolic disorders, neonatal hypoglycemia, traumatic brain injury, tumors, vascular events, epilepsy, or even some drugs. So why is it important to talk about CVI today? It is because, as Susanna said, it is the main cause for visual impairment in children in high-income countries. It is around 30 to 40% of all cases of visual impairment in our children. But if we talk about incidence instead of prevalence, it goes up to 50%. So it's a major cause for visual impairment in our children. And as a study in the UK showed, perhaps CVI is not so frequent, but they found that in the UK, more than 3% of all the children in mainstream primary and secondary schools had at least one problem related to CVI, related to brain damage with vision consequences. So when we think about that, it means that at least one child in every mainstream class in primary or secondary schools may have vision related to this problem. So we all know that it's underdiagnosed, and probably that's the reason why we are talking today, because it's such a challenge to identify and to suspect this problem. But cerebral visual impairment is often described as an umbrella term, and that is so because it encompasses a wide range of visual dysfunctions that may vary significantly from one child to the other. So and it's easy to understand. I mean, the range of potential causes is so wide, and the anatomic parts that can be damaged are so different that usually it's said that every child with CVI has a unique visual profile. So we are trying to make a summary about the potential visual dysfunctions that can happen in CVI. So let's start with lower order visual deficits, which means the problems due to damage in the posterior visual pathways. I mean, from the chiasm to the brain. And we will talk about decreased visual acuity, reduced contrast sensitivity, and visual field losses. Then the higher order visual deficits, which are due to damage in the associative brain areas, as we will see. And there are many of them, such as difficulties with complex motion, or object or face recognition, or visual search, or many others. But we have also, we need to know that higher order visual deficits are not dependent on lower order visual deficits. And sometimes there are children that only present lower order deficits, while some others mostly present higher order, and most of them, both of them, like in different levels. But finally, although it's not they are not diagnostic deficits for CVI, it is also very important to disentangle the contribution of many other additional visual comorbidities that usually appear in these children with CVI. And they are due to congenital ocular abnormalities, or to genetic conditions, or to maldevelopments. So we're going visual function by visual function, explaining what can be found in CVI children. So as far as visual acuity, if you remember the definition we said for CVI, it's interesting that it doesn't mention visual acuity at all. So it means that any visual acuity can be found in children with CVI. And it's interesting because it wasn't so from the beginning. At the beginning, low visual acuity was a diagnostic criteria. It's not anymore, because any visual acuity level can be found in these children. Sometimes it can be accurately measured with optotypes, but some others it can't because of the age or the characteristics of the children. So it has to be estimated based on their behavior. There are many ways for grading this visual acuity or this visual function, but I'm presenting this one because it's probably one of the most commonly used. Visual acuity is graded from 1 to 6, from light perception to visual acuity normal or almost normal. As far as contrast sensitivity, it's usually even more effective than visual acuity itself, than high contrast visual acuity. And it's interesting because it's not very frequently assessed in current pediatric ophthalmology clinics. So I think it's something we should be aware of to start measuring it if possible. And one funny thing is that it usually improves with age, much better than high contrast visual acuity. Well, visual fields loss, of course. I mean, once we have seen that CVI can be due to damage at any level of the posterior visual pathways, it is easy to understand that almost any visual field defect can be found in children with CVI. It depends on the location and the extent of the brain damage, but there is not always a direct correlation between the anatomical pattern of the damage and the visual field defect, and it's important to know. There are even cases with absolutely normal visual fields with damage in the optical radiations found clearly in MRI, and it's quite frequent in children with damage occurring prenatally due to reorganization of their brain structures due to neuronal plasticity. So there is like most of the times there is a correlation between the anatomy and the loss, but it's not always so clear. This is, for example, a case, it's not a case from my office, but from a publication, but we've seen many of these, or some of these. It's quite a frequent case. It was a 13-year-old girl who was referred with a diagnosis of juvenile glaucoma because of the aspect of the optic nerve with a large gap. And this was the visual field, and something was not very clear, and probably they suspected that the visual field was not clearly correlated with the glaucoma. So they performed an MRI, and that was what they found. They found, as you can see here, periventricular white matter damage was indeed related to perinatal hypoxic ischemic events and not explained by a glaucoma. And it's something that happens quite frequently. Sometimes this visual field loss may be related or may be associated with many others neurodevelopmental or visual dysfunctions. And this is an example of this. It's the damage the trigone of the lateral ventricles, which is this part there. And it's an interesting anatomic part because many things are happening right there. First, the optic radiations, as we said, like the upper bundle of the radiations, but also the superior longitudinal bundle, the dorsal stream, and also the corticospinal tract. So it means that just in this small part of the brain, so many things are happening that damage at this level would give rise to inferior visual field loss, spastic diplegia, and visual motor dysfunctions or dysfunctions due to dorsal stream. So we talked about lower order afferent visual defects, and when we move to higher order, we have to again remember these anatomical structures, the dorsal and the ventral visual streams. So as far as the dorsal stream, children with damage at this level will suffer from difficulties in vision-oriented movement, which is called optic ataxia, motion detection problems, perceiving moving objects in the environment, but also perceiving the objects when they are the ones in movement, distinguishing between moving and stationary objects, and it makes them feel overwhelmed in complex visual scenes. Situations with many visual stimuli or many people or things moving and other not moving, it's quite overwhelming for them. They also exhibit spatial awareness deficits, navigating through space or calculating relative positioning or poor depth perception, and also impaired visual motor integration. As far as the ventral stream, they have difficulties with object recognition, which is known as visual agnosia, impaired face recognition, which is prosopagnosia, identifying facial expressions. It means not only to have difficulties like recognizing people, but also understanding like facial expressions, like non-verbal language, which is quite limiting for them. Also mistaking strangers for familiar people and vice versa, and recognizing people in pictures. They have issues with form and pattern perception, anomalies in color perception, problems with visual memory and crowding effect. It means difficulties discerning individual objects when they are presented in cluttered environments. This problem, crowding effect, has a huge impact on daily activities. For example, reading fluency, or identifying people in environments with many people or many stimuli. So we've talked about lower order visual deficits and then higher order visual deficits, but as I have said, we have to think about all the ocular comorbidities these children face. As far as the anterior visual pathways, since prematurity is one of the major causes for CVI, we have to keep in mind retinopathy of prematurity and all its consequences. Also inherited retinal disorders such as retinal dystrophies or colobomas, and toxicity or adverse effects from medications such as anti-epileptic drugs. As far as the optic nerve atrophy is the main optic nerve anomaly associated with CVI. Also the optic nerve hypoplasia with the double ring sign, frequently associated with some drugs consumed by the mother, and the optic nerve capping, which is this is a case I talked before about the 13-year-old girl with white matter lesions, and this was her optic nerves with a large capping, which is quite frequent in preterm children with this pattern of damage. Another comorbidity very frequently associated with CVI is poor oculomotor control. Sometimes it's nystagmus, and some others are unstable fixations, intrusive saccades, or smooth pursuit deficiencies. Here you can see 2 videos from the gazes of a control child on the left and a child with CVI on the right. You can see that the control child has like steady fixations, and the saccades are quite fast and moving quite accurately from one stimulus to the other. But on the contrary, on the right side, fixations are less stable. There are lots of intrusive saccades, and saccades are slower and less accurate. And oculomotor apraxia would be the most severe case of poor oculomotor control. The problem with oculomotor apraxia is that you can estimate that they are not able to see the patterns, and their visual acuity might look lower than it is indeed, because they are not able to move their gaze to one stimuli to the other. But if you see here, when he sees the light, he's more interested in light. He's not able to move the eyes quickly from to the object, but you see kind of a reaction. He starts moving the head and moving the neck sometimes. And they use these movements to induce reflex saccades to end up positioning the stimulus in the fovea. So there is a reduction of intentional saccades, but preservation of vestibular reflexive saccades. As far as estrabismus, there is a high prevalence of estrabismus in these children, and exotropia is more common than esotropia. There's an interesting kind of strabismus, which is dyskinetic strabismus. It means that sometimes you see like an exotropia in far distance and an esotropia in near distance, or even in near distance, you see that the directions change during the assessment. And it is even more common in cerebral palsy. It's important to note that horizontal strabismus has a high rate of spontaneous resolve, which means that you have to be very, very careful recommending surgery. So it's better to perform several serial evaluations in different situations before recommending a surgery to these kind of children. As far as refractive errors, there is also a high prevalence of them because of failure in physiologic emmetropization, and myopic astigmatism is probably the most common. They usually have accommodative insufficiency, so it is important for them to be aware of that, because treatment with optic correction should be recommended not only for significant refractive errors, but sometimes for milder ones, because they are not able to accommodate as a typically developed child. And also to suspect accommodative insufficiency, because sometimes they need correction. Most of the times the things happening to these children take place in near vision. So it's important to make sure that they have the best correction for near vision. So sometimes they need like bifocal or monofocal prescriptions for near vision. And apart from all these functions, it's important to know some behavioral characteristics for these children. They have abnormal light response, which might be light gazing, and they are continuously fixating on lights, but sometimes it is photophobia. They have a very high fatigue from visual tasks and throughout the day. So parents say that sometimes they look like it seems that they see perfectly, but some others, their vision is very poor. So their visual responses are very variable throughout the day, even to the same stimuli. They always say that responses are better to familiar than to novel stimuli. So that's why sometimes it's interesting to use their own toys during the assessments. And they have like a very typical behavior, which is that they use central vision to probably to fixate on their stimulus of interest. But once they want to reach it, sometimes they move their gaze and they use peripheral vision for reaching them. And another interesting thing is that they have reduced responses to different visual stimuli when there is multisensory stimulation. So if there is a lot of noise or a lot of people touching them or many other sensory stimuli, sometimes their visual responses are poorer. So this is more or less the scheme of all the dysfunctions they may exhibit, but we have also think about the prevalence of other neurodevelopmental comorbidities. They have around 60 and 67% of these children have other comorbidities, such as cerebral palsy or developmental delay or other motor impairments, which makes everything even more challenging for them and also for us to make an accurate assessment. Just finishing, how do they progress? So we know that there is a spontaneous progression and improvement based on their behavior in most of the children, and it is important to know, because sometimes you examine a very young child and you see a very poor visual function. It's important to know that things can improve a lot throughout childhood. And it depends on many aspects, but we know that improvement is going to be worse if they are older, if the age at the onset of the symptoms is older. If they have cerebral palsy, certain causes are associated with worse improvements, such as hypoxic ischemic events. Epilepsy treated with more than 3 drugs is also a bad risk factor, and abnormal fundoscopic findings. And on the contrary, sometimes when they change the treatments and they are able to treat like a refractory epilepsy or any other systemic disease, it's very frequent that we see an improvement in their visual function. So just for take-home messages, is that we have to be aware that despite of being the leading cause for visual impairment in childhood, CVI is still really underdiagnosed. CVI is a spectrum disorders with visual function varying widely depending on the brain areas, the damage, the child, the comorbidities. So every child with CVI has a unique visual profile, and clinical manifestations may be structured in lower order visual dysfunctions, higher order visual dysfunctions, and visual or neurodevelopmental comorbidities. Thank you so much for your attention.
Thank you, Victoria. Really nice presentation as usual. Let's go on and give the floor to Sofia, and we can answer some questions if you have at the end of the presentation.
Good afternoon, and thank you very much for inviting me to take part on this webinar. And thank you, Victoria, for such a wonderful talk. I would like to talk about how to explore a child with CVI. It can be extremely challenging at first, but if we do it thoroughly, we can obtain much more information than we would initially have thought. This is the index of the talk, and I will start directly. Assessment of a child, and especially of a child with CVI, is limited by time and behavior of the child. The approach to assessment of a child with CVI should be tailored, especially according to the child's age and the severity of the visual dysfunction. And we should make a clear distinction between the visual function, which we assess monocularly, and the functional vision, that is the binocular vision of the child and how they behave in their own environment. It is true, and it is very important to be aware that carers and parents might be unaware that the child's behavior could be related to a visual dysfunction, and that we have that the child might show problems in school in spite of having a normal regular ophthalmological examination. The main problem we are facing is that we don't have standardized clinical protocols to investigate and to be able to diagnose CVI, which is one of the main difficulties. I think when we are starting to explore a child with CVI, we should do a very good structured clinical history taking. Always perform a correct anamnesis, the child's history and the pregnancy history. The mechanisms, as Victoria has explained very well, within the human brain responsible for vision are extremely complex. So I think it is very useful if we use a structured questionnaire, which can help us guide the design for an appropriate educational and habilitative strategies, and especially to try and distinguish where the child might have the problems. Depending on the age of the child we are assessing, we use different type of questionnaires. In preverbal children, especially between 0 and 24 months, we like to use the preverbal visual assessment questionnaire, which you can see here. It is 30 questions divided like in 4 items: visual attention, visual communication, visual motor coordination, and visual processing. And what I usually do is, whilst the parents are in the waiting room with the child with the eye drops and waiting for them to dilate, I usually give the parents or the caregivers the questionnaire for them to reply during that time. And the preverbal visual assessment compares the vision of the child we're assessing with those children who have been born 37 weeks or more, and what we consider that between each age group they should be being able to achieve. In patients who are older and who have a visual acuity of 0.1 or higher, I like to use a questionnaire proposed by Datan, which assesses 7 sets of questions. It is a very long questionnaire, as you can see here. It is 51 questions, which I usually always give the parents during the waiting room, but it assesses 7 items: visual field impairment or impairment visual attention. It assesses impairment of perception of movement, and different items which try to help us explore the dorsal stream: difficulty handling complexity of a visual scene, impairment of guiding the movement of the body, impairment of visual attention, and how they behave in crowded environments. And also we can assess the ventral stream with some questions concerning the ability to recognize what is being looked at and to navigate by means of visual recognition. And as you can see, it is a long questionnaire and it takes time, but it gives you information about what you cannot explore in the clinic, but how they behave in school or how they behave at home. We also have another inventory of questions which we can ask children who have profound cerebral visual impairment, who have a visual acuity below 0.1. And it can also help us know how they behave outside the clinic. This structured clinical history taking can give us information about what Victoria has talked about in the previous talk. The most common damage is the posterior parietal lobes, and we will be dealing with children who have simultagnosia. That is, that they have difficulty in identifying an object, a person in a crowded, or an object in a crowded scene, selective visual affection, or optic ataxia. They have difficulty in grabbing things, and so by knowing all these things, we can change their environment to make their life easier. If we have, so we said that the most common is parietal damage. It is rare to have isolated ventral stream dysfunction, but it can exist. And that would be a person who has difficulty in identifying faces, prosopagnosia, identifying objects, object agnosia, or impairment of the ability to root find. But it is also common to have an association of both damage to the dorsal and ventral stream. However, even though these questionnaires are extremely useful, it is obvious that it has its limitations. We can have children who get close to the TV, but not because they have simultagnosia or they have problem in guiding visual attention, but because they have hearing disabilities. Or we have patients who have maybe difficulties due to intellectual disabilities, or patients who have difficulty in playing in the park, going up the slide, or navigating through steps and pavements, but because they have lower limb motor problems. Or it is also pretty common to be examining a child who has an autistic spectrum disorder. And so it is really difficult to discern whether they are having difficulty in the items explored in the questionnaire due to CVI or due to their autistic spectrum disorder. So it is very important to do further research to develop and to define optimal clinical questioning strategies. And as Victoria said, the patterns for a visual dysfunction are unique for each individual. Once we have done a structured clinical history, we always have to examine the refraction to distinguish if there is a disorder of refraction or an impaired accommodation. In young children, I think it is worth persevering because vision can improve progressively without the child's awareness. And the first time they wear the glasses, it can be this visual clarity may be overwhelming initially, and that might be the reason why they take off the glasses, but then they get used to it and they are happy to keep on wearing them. I usually always try at least once to prescribe the glasses to see if the patient is comfortable with them, or if the parents tell us that they are more active or more connected to the environment. But it is true that if the potential improvement with the glasses is less than the level of vision due to brain damage, it can be a reason for them to reject the glasses. So we can try at least once, but if they're rejecting them and we have the feeling that they have a very low vision, maybe we can not all, make them wear them. Then it is important to assess central vision, as we will share the visual acuity. Depending on the age, we will use different strategies. In this video, we can see how we are assessing with the LEA with preferential looking, with the brackets. We will assess contrast sensitivity, color testing, and try and do a central visual field. We might have a normal regular eye examination, which appears normal despite having a child with CBI. And as Victoria said also, it is very important to do always a fundoscopy in these patients. In a patient who has brain damage, we have to assess always the visual field and the attentional impairment. Depending on the age, we will use STICAR or Humphrey visual field testing. In a patient who has a damage to the occipital lobes, in the exploration, we will see that they try to turn the head to see the image. However, in patients who have a posterior parietal lesion, they will show a lack of attention to the opposite side, so they will turn their whole body or even bend down to try and look towards that side. Or they can have a combination of both turning the head and turning the full body to access the information. It is pretty common also to find that in patients who have had bilateral posterior parietal damage, they have a lower visual field impairment or low clarity in their inferior visual field. So it will be a patient who looks down or approaches floor boundaries. They can have difficulty going up the slide in the park, or even trying to jump into the swimming pool can be challenging. It is also important to assess the perception of movement. We will be dealing with children who show difficulty in seeing moving traffic, so it can be challenging to cross the road, or identifying parents in a crowd in the patio, or they prefer to watch a TV with slow-moving things rather than with fast-moving things on the TV. I think it is also useful to try and use visuospatial abilities test. This is a very long test, and it requires a good cooperation from the child, but you can also obtain pretty good information, and especially because it is a motor-free test, so it can be used with children who have motor problems. And it assesses 7 categories of visual perceptual skills: visual discrimination, visual memory, visual spatial relations, form constancy, sequential memory, figure ground, and closure. Significant disability would be defined as a total score less than percentile 5 in all subtests. We can also try and see how they do object recognition. The problem is that available object recognition tests are not available under age of 6 years, but you can play with different things in the clinic to try and see if at least they manage to put the square, the circle, or the triangle in the box. Or we also have some mailbox games for them to try and insert the letter into the mailbox. And it is also interesting to use artificial intelligence devices to evaluate visual function. This device, DIVE, Devices for Integral, has been developed by Victoria Pueyo and some collaborators, whom I have the pleasure to share this webinar with. And it helps, this eye tracking technology helps assess visual function in pre-verbal or non-verbal patients. So I think in the future, if we manage to incorporate these studies in the clinic, we can obtain a lot of information also. It is very important also in the clinic to study eye movement disorders. We have to see if we have nystagmus, inaccurate saccades, deficient smooth pursuit movements, strabismus, apraxia of gaze, difficulty in tracking fast-moving objects. But it is true that the relationship between all these findings with the visual prognosis is still unknown. And we can also use other tools and imaging to complete the exploration. We can use OCT to explore the macula, the optic nerve, and the retinal ganglion cell layer. Sometimes visual evoked potentials or ERG is required. And I think it is very useful also to go back on the history and see the transfontanelar ultrasound they do to these patients in the first weeks of life. And some of them have also MRIs of the brain, and it gives us information of a wide spectrum of conditions which can be related to CVI, such as brain malformations, periventricular leukomalacia, occipital damage, closed head injuries, or hydrocephalus. But it is true that CVI has also been described in patients who have no structural brain damage. So the main things we take-home message, I think that structured history taking is crucial. It is true that they are time-consuming examinations, and it is very difficult to have 30 minutes for each patient, but we try and do as much as we can in the little time we have. Each child is unique, and identifying CVI pattern is the first step to help and support the patient and family. We should try and begin the interventions soon after discharge from the neonatal unit, because brain plasticity is at its highest potential, and try and develop a patient-tailored program of rehabilitation involving parents, teachers, and specialists, and trying to empower families to better support these children. And my second talk will be how to write a report on a patient who has CVI. As I've done before, as I've just said, anamnesis is very, very important. We have to gather pregnancy, personal and family history of the patient. Try to also include the neonatology. I like to go back onto neonatology examinations and include in my report if they have any images, ultrasound or MRI, and the results of those images. Try and look back to see whether they had retinopathy of prematurity and whether they required treatment or not. And I think it's also interesting to include a conclusion of the notes from the neuropediatrician to see how their neurodevelopment is going on, how is their school performance, and how they relate, how is the relationship with their peers. So the main objective of what we should include in the structured clinical history is to try and evaluate whether there was dorsal stream affection or ventral stream affection, and writing whether they had simultagnosia, optic ataxia, prosopagnosia, or object ataxia. And we can write a few notes for the person who is reading the report to understand whether the patient might have difficulty when you go and pick up your child in the school patio. Try, for example, to always wait in the same place, or wear something bright or something that can help the child identify you in the upper body if we think that they might have a low visual field defect, such as a bright scarf, a hat, or a jumper that they might recognize. Letting them know that they might have an inability to read facial expressions, and that this might make the child misunderstood as a lack of empathy. So try and use clear language to convey emotions instead of using your face to convey the emotions. And try, for example, in the house or at school, if it is possible, to keep a tidy environment to avoid frustration of the child. Let them know that this might mean that if their guidance for reach is poor, that they might miss things or knock things over, and that if they have prosopagnosia, that they are not really trying to ignore the people on purpose, so that this is a problem, and so that they don't cause any offense, and that they might have an inability to recognize shape, form, or color. I think including all these things in the report might be useful for the teachers and for the parents to be aware of. We should always include the visual acuity. Depending on nonverbal or verbal, we will write it down. We can also write down the result of the pre-verbal visual acuity assessment questionnaire. And when we're talking about the visual acuity, it is true that in nonverbal, we usually write it down binocularly. And if it is possible, we can do it monocularly. But in verbal, we usually always test it monocularly. And whether when we are taking the visual acuity, if they are adopting a normal head posture or not. And we would like to write down recommendations concerning visual acuity, whether we think they have amblyopia or not, or whether patching is required, and how many hours we recommend. In case in order to reduce the crowding phenomenon that many of these patients have, we can recommend them to use a ruler to underline their line which is being read, especially when they are learning to read. We can increase the font size, use high contrast, high illumination rooms, or even have to use photophobia sunglasses if necessary, and try to make a few notes on visual performance. Always include ocular motility, both internal and external ocular motility. We can try to describe whether the strabismus we are seeing can be secondary to a visual field defect or not. If the strabismus can be due to nystagmus that is being blocked in convergence, explain whether the abnormal head position can be due to diplopia, and explain whether or not they have absence of 3D vision, in which case they will have a poor depth perception also. We would recommend, if the patient needs for these ocular motility problems, whether we recommend glasses or whether we recommend surgery or a botulinum toxin injection, and consider telling the patients not to take the patient to a 3D cinema because they will definitely not enjoy it. We always have to do a refraction under cyclopedia. We will write down if the patient has myopia, hyperopia, astigmatism, or anisometropia, and make maybe a few notes on what this means and where the difficulties can be in the patient, and explain the need of an optical prescription, whether the glasses are needed in class, only for a long distance, or if they should be worn all day, if we recommend bifocals or progressive, and let them know that this might be a concern of the patients because they are already wearing hearing aids, and then you tell them that they have to wear glasses. Well, tell them that it is possible to adapt glasses in patients who are wearing hearing aids, and whether specialized filters are recommended. Explain if they have amblyopia and the need of patching, and always be careful with patching in nystagmus. If patching is not tolerated, include whether the possibility of treating with atropine, and also trying to make a note for the teachers to let them sit on the first rows in the classroom for them to have a better visual function. Always include anterior and posterior segment examinations, whether they, as Victoria said, that CBI can also be associated with comorbidities of the eye, whether we have corneal opacities or cataract, and these have implication or not in the visual development if they affect the visual axis, whether we recommend surgery or patching. Always include fundoscopy to identify if we have any problems in the optic nerve, macula, if retinopathy of prematurity treatment has been needed, or if we have any other condition in the fundus. It is very difficult to give a visual prognosis. Try and not give it because we really don't know what will happen in the future, and consider patching to prevent or treat amblyopia. Always try and explore a visual field. Knowing that in non-verbal patients, we usually do it binocularly with a sticker, and in verbal, we usually do it monocularly, and write down on the report which visual field we think might be affected, and explain what difficulties might be related to these visual field defects. Try maybe to arrange the sitting in the classroom depending on what side of the visual field might be affected. Explain to the parents or caregivers that these children might trip over things repeatedly if they have lower field visual defects, and ensure that everything is high for them to see correctly. And it is true that if they don't see, they will not form memories on what they don't see, so they will trip over and over again, even if they are in a controlled environment or at home. Try and recommend to use a lectern to help reading or studying in lower visual field defects. Awareness of difficulty in started reading in patients who have a left visual field defect. So this should be explained to the teacher. Also that these patients might have difficulty in going up slides in the park, jumping into the swimming pool. So maybe the physical education class teacher might be aware of this impairment. And we should also try to include, if they have been performed, or if we find necessary, visual potentials, ERG, OCT, or visual perceptive test. So to finish with, this report should be in an accessible language for caregivers for them to understand. We should always include an ophthalmological diagnosis. We should make a few points on functional vision, understand what the child can see comfortably for them to promote learning. So how big things have to be for the children to see them. So we maybe have to adapt the font size. We have to use high contrast things, see if they see better things which are in movement or no movement. Or maybe we have to make a few notes on other factors, such as, for example, giving more time in school for exams, use optimal lighting. And it is very important for everyone to be aware that functional vision can vary. It can be worse when there is noise, when there is clutter, when there is stress. And also that it can be helpful to find out what their functional vision is at home in their best environment. We should always include a treatment plan, where we say if we recommend an optical prescription, if we recommend a stimulus of one of the visual fields where we have found a possible defect, if we recommend injection of toxin or muscle eye surgery, and also a few recommendations for physical and occupational therapy on the early attention programs these children go to. And to finish with a few conclusions and plan, we have to promote awareness and adaptation to make the child's work more efficient, maybe avoid certain environments, avoid going to supermarkets, or avoid going to malls where there are many people, give more time at school for activities, exams, maybe sit the child on the first rows of the class to have a clear view of the teacher and the whiteboard, and with not having anyone sitting in front of them directly. Because the main objective is to make a difference between optimal learning and the impossibility of learning. So it is important to help families understand CBI. I think it is very useful to refer the parents or the caregivers to information. I usually recommend them to go into the website. These two websites I like very much, CBI Scotland and Perkins.org. Because this can open an entire world of understanding and make the world less overwhelming for these children. Thank you very much.
Thank you, Sofia. Thank you. I think that both of you have a lot of credit working with these kids. Okay, thank you, Victoria. Thank you, Sofia. Thank you very much.